What I'd like to do at the beginning today really is to answer any questions or hear your comments or reflections about the readings or about the past lecture. If there are any questions, and I'll do this at the beginning of every session in terms of anything that's come up that you'd like to raise and that we can discuss. So, I'm going to talk more about it today, but the idea was introduced by the anthropologist Mark Nichter, who at the time was working in South Asia with Brahmin women. And he talked about the idea that there were culturally prescribed ways or culturally accepted, known, common ways of expressing distress. So he used the word idiom the same way you would talk about a linguistic idiom. The idea being that if you speak English or French or Japanese really well, then you know all kinds of ways of saying things that are colloquial ways, that are idiomatic ways. They're not strictly the textbook way, they're the way that a native speaker speaks. And often those are metaphorical, often they're indirect or whatever, but they're understood by people within the same culture. Because they are idiosyncratic, because they require a lot of knowledge of language, they're often misunderstood by outsiders, and I'll talk about that today. But he listed all kinds of things. He listed complaining of fatigue and pain. He listed, in this case it was women in South Asia, people complaining of vaginal discharge and having to go to the doctor for that. Burning the family dinner accidentally was an idiom of distress. It was a way to communicate to your husband that you're pissed off. So, and the idea being that what makes it an idiom is the same way that you say something is a linguistic idiom. If you say, it can be literally a linguistic idiom, but he meant it more broadly. That's why he was calling it a cultural idiom, partly because he was tying it not strictly to language, but to culture, which is important too, because you could have within the same language community different cultures and different idioms, and you have that clearly in different subcultures or social classes or whatever where people use things differently. I'm going to talk more about it today because I think it's a very important idea, partly because not only within mental health practice does it get do these idiomatic expressions get misinterpreted, but even within cultural psychiatry, I think, and I made that argument a little bit last time when I was showing these supposed culture-bound syndromes and implying that some of these are better thought of not as syndromes but as idioms of distress. So nerves, for example, is not really a syndrome. There's so many things that could be attributed to nerves or explained as nerves or whatever. But when someone says, oh, my nerves are bothering me, we know that they're troubled by something. Doesn't mean they have an anxiety disorder or depression or any other specific thing. They may not have anything at a clinical level. It may be subclinical in terms of the intensity, but it's in everyday language. And then I use the example of depression, which has become an idiom of distress. Or another common one in Quebec is burnout, which was very popular in the past. And so again, you could try to develop a biomedical theory or a psychosomatic theory of burnout, but it doesn't function that way anyway. It functions as an everyday way of saying, I think I'm burnt out, I'm getting burnt out, or whatever. Now there may be other things going on, and there may be and again, we'll talk about it today, there may be a psychosomatic or sociosomatic or other process lying behind the idiom, but the idea of talking about an idiom is, it belongs to the pragmatics of language, the pragmatics of communication, and so it's looking at how language or how other forms of communication are being used. And that's what you're classifying rather than a disorder. And the argument is that that's a more accurate way of understanding some expressions and then trying to decide what their implications are. And so, in fact, for DSM-5, we've written an introduction that explains in so many sentences what an idiom is, a cultural idiom of distress, with the idea that this is a useful conceptual tool for clinicians. Yeah, if you said, I'm interested in studying nerves, I want to know what the neurobiology of nerves is, you're probably, getting off on the wrong foot. You probably have not described a discrete entity in a way that's going to be very fruitful. But if you said, what are the pragmatics of talking about nerves in everyday life, that's actually a good, useful research topic. How do people use the language of nerves to communicate suffering? How's it understood by other people? What are the family dynamics? All those other things are interesting, including what happens if you go to the doctor and say your nerves are bothering you? Because at that point what's happening is the clinician is filtering this language of distress into certain categories. And I'm kind of anticipating my whole talk today, but that's okay. It'll just be that much clearer when we get to it. I think the answer is yes, but when you focus on a symptom, you're thinking within the semiotics of medical diagnosis. So now a symptom is a bodily event or experiential event that the person's reporting. It has a meaning vis-a-vis a diagnostic system, and that's the way that you're thinking. When you're looking at it as an idiom, you're really asking, how does this function communicatively to other people? And the implication of a cultural idiom is that it has communicative meaning and value and it's understandable within a cultural community of some kind or a local community of some kind. So this one and the same event could function both ways, but the thing is, with an idiom, you don't actually have to have the headache. I mean, an example would be, you could say to somebody, you're giving me a headache, you know, and you don't literally mean you have a headache, although the origin of that phrase was from times when people really did have headaches as a result of, you know, some, you know, troublesome person or event, but now it's just become a linguistic idiom. And as I say, the slide between linguistic and cultural idiom really is just one of emphasis, since language and culture are usually very close, but you know, they don't have to be, in the sense that you can appear to be using the same language but be using it differently because you come from different cultures. Or vice versa. You can, I mean, we live within one culture with two languages here to some degree, or, you know, overlapping cultures anyway. So you have people who will use two different languages but maybe using this similar cultural frame at that moment. Yes, yeah. And again, I'm going to talk about that today. You guys are, it's perfect. We're obviously totally in sync because I don't have to do a structured lecture. I'll just respond to you and we'll work our way through everything. But that is the topic today, is about bodily expressions of stress. There's actually a lovely art history book called Gestures of Despair that talks about medieval art and the ways in which the body is shown expressing distress, with the idea that, and again, we'll argue this today, that there are universal elements to this, but then there are culturally particular elements. So we can see commonalities. You can meet people from all over the world and you can pretty much tell if they're in pain or not, or possibly anyway. You can't tell for sure, but you know. But then there are other things that you might find very misleading, and I'll say more about that. Was there anybody? I think there was one other. No, that's about it. Okay. Yep. Okay. They're for it. No, no. As I mentioned, it's a complicated issue, partly because, on the one hand, the whole thrust of psychiatric nosology is to have some kind of generalizable knowledge that hopefully is based on scientific research that applies to human beings everywhere, certainly to all the different varieties of human beings found within the borders of the United States. I mean, that's their mandate, and that is a fair slice of people from everywhere, since people have come there. So that's the aspiration. There's also the assumption that many people make, that we've begun to challenge in the introductory lecture, and we'll continue throughout this course, that mental disorders reflect processes that are universal in people everywhere. And that's partly true. I think that is the case, and we'll try to show how, but it's not 100% true, that there are variations in those processes. But I would say that within mainstream psychiatry, that's not widely accepted. The assumption within mainstream psychiatry, both within the American Psychiatric Association and internationally, is that the underlying mechanisms of psychiatric disorders are universal, that they are biological, and that implies that they're universal. And maybe I made the point last time, but it's worth reinforcing again now, that the fact that something might have a biological basis does not prove that it's universal, because there's biological variation in human populations. And oftentimes when the WHO describes cross-national epidemiological study, the type that we mentioned last time, they'll comment somewhere in the text, you know, we found roughly the same prevalence everywhere. If that's the case, it's very odd, because there's almost no disease. You could look at tuberculosis or malaria or different kinds of cancer. None of them are evenly distributed across the human population, largely for biological reasons, because there's genetic variation in populations, because there's environmental variation in exposure to vectors, because there are actually variations in the nature of the bacteria and the virus that are dominant in different sort of ecosystems around the world. So there's every reason to think that biology is also a source of variation. The flip side, that there's sort of built into this duality of you know, culture, nature, or biology and culture, is that somehow culture is going to be always unique and local. But in fact, all cultures deal with similar existential predicaments, similar facts about the body. We're all born, we all grow old and get sick and die. I mean, these are the part of the noble truths of Buddhism, but they're existential realities. And so every culture is dealing with that. Every culture is developing some kind of set of ideas about that. In fact, you could argue that's a big part of the motive force behind religious systems, is to deal with those deep existential problems of human existence. So you could also say that culture is a source of universality, not just of particularity. So all of this is an argument for saying that both things should be put together. So to come back to your question, though, as to the stance of the American Psychiatric Association toward this, on the one hand, there's this theoretical, implicit or explicit theoretical stance that if we know the biology, if we know the underlying mechanisms, then we have universal knowledge, so we don't have to worry too much about culture beyond being able to communicate with people. On the other hand, there's the political recognition that you have a diverse society in the United States, which is, again, the constituency of the APA. And as I mentioned last time, because you also have a lot of diversity within the profession itself now, there is a push from within the profession to say we really should be paying more attention to culture and to language and so on. And that's come primarily, the largest segment in terms of this diversity within the US are Hispanic psychiatrists, but there's also a significant number of Asian American psychiatrists and other groups, and so they have pushed for some attention to these issues. For DSM-4, there was an external committee funded by the NIMH called the Culture and Diagnosis Work Group that did a lot of work on culture, and then that was given to the work groups who had the formal responsibility from within the American Psychiatric Association to develop cultural issues. For DSM-5, there is no such process. There is a work group on gender and cultural issues, which is a small work group that has involved a larger number of people outside the immediate work groups for DSM-5 in looking at cultural issues. And those people who are involved, and it's true actually for all of the DSM, that there are people involved from all over the world, not just from the United States. And in the case of the cultural work, there are people involved from the UK, from some European countries, from India, and from a number of places. So there's a bit of input from different places, reflecting the fact, as I mentioned last time, that even though DSM-5 is officially an American or US nosology, it has important functions globally, and people want to respect that and support that by paying attention to culture. So I hope I'm giving you a bit of the notion that on the one hand, theoretically, many people would see no strong reason to worry too much about culture in a lot of the core structure of the nosology, that it would be viewed mostly as just a problem of applicability, communication. But politically, there is more recognition and acknowledgement of the importance of addressing culture. So that's kind of where we're at right now with DSM-5. And we'll see what actually happens because there's a lot of apparent openness on the part of David Kupfer and other people involved at the top, the administration, the construction, the editing of the DSM-5. But we don't know what will finally come out in the wash because there's a lot of competing forces. Please. Well, again, I think that'll come out throughout the whole course because in a way we'll be talking about different kinds of distress. So I think let's reserve that for the moment. In using a word like distress, we're trying to find a word within English that covers a very broad terrain, precisely because we want to talk about physical pain, emotional pain, anxiety, nausea, worry, too many thoughts, all kinds of things that people might find troubling. And it's an interesting question, and again, it'll be one of the topics for today and throughout the course. Is there a general phenomenology of distress? Is there a shared element across things, or are there many different kinds of experiences? If there are, how much are those experiences rooted in the body and bodily physiology? How much are they a function of the way we think and the way we relate to other people? So that's a good segue then into the talk today, because I'm really, all the things we're talking about are things that you're going to hear echoed in what I wanted to present to you today. So the focus today is on somatization and idioms of distress. And in talking about somatization, we're talking about the body, about bodily expressions of distress. And interestingly, this has been at the center of interest in cultural issues from the beginning. I mentioned last time that cultural psychiatry at McGill began with the work of Eric Wittkower, who was a psychosomaticist. He was interested in psychosomatic medicine. And for a long time, there's been a kind of conjunction between people interested in psychosomatics and people interested in cross-cultural work. And there are reasons for that that will become clear as we go along, so those two things have a close history. This is what I'm going to cover today. I'm going to talk, first of all, about the concept of somatization, then about the problems of dualism in medicine. I'll talk about specific forms of somatization in clinical care. Then something about the semiotics of bodily symptoms, that is the medical semiotics, how we treat certain experiences as symptoms and signs of illness and what that means in terms of diagnosis and so on. And then more broadly about this idea of cultural idioms. And then the invisible bullet points that I forgot to put on this slide because I was distracted earlier today, we'll be talking about the nature of embodiment. And the whole question of how experience is expressed in and through the body, and then how those experiences of embodiment are grounded both in bodily processes, but also in social processes. And that really is the central interest in recent years in a lot of medical anthropology, and at least experience near medical anthropology. And then we'll end with talking a bit about the larger, again, social processes that those things are embedded in. So just a few words about somatization as a concept. This is a word, you can see from its form, that already implies a kind of a process of making something bodily. Something is being somatized, it's being made of the body, and that raises the question, well, what is it that is not of the body? I mean, what is it that's not somatic that's being made somatic? So you get a hint already that behind this word is a dualistic ontology. Behind this word is the notion that there could be something that is not somatic that is now going to be somatized and made somatic. And historically what that was psychological distress, emotional distress. And the term somatization was introduced in the 1920s by psychoanalysts, arguing that there were certain kinds of psychological suffering and distress that could be translated into bodily symptoms. And so there was a whole question then of, well, what's the mechanism of that translation? And this struggle to make up kind of psychosomatic theory that would explain how things go from the psyche to the body went on for 50, 60 years or more. In some ways it's still with us. In the late 50s, there was a book by Deutsch called The Mysterious Leap from the Mind to the Body, which really captures in a phrase, I think, this whole dilemma of mind-body dualism, that not only do we have to get from mind to body, but it's a great mystery as to how we could ever get from mind to body because of the underlying ontology. What I mean by ontology is a notion of what is out there in the world, what kinds of entities and things are out there in the world. And we inherit a long tradition in the West of the idea that there is mind that is somehow disembodied, and there is body that is very physical and very present as a material substance. Not only do you have that dualistic ontology, but you also, as I mentioned last time, have a long tradition of a notion that the mind and mental phenomena, mental expressions of distress, psychological expressions of distress, are more developmentally mature, advanced, sophisticated, whereas bodily expressions are more immature. There's a paper from the 40s by Jürgen Reusch called The Infantile Personality, in which he's arguing, I think that's anyway, it has infantile in the title, and it's talking about psychosomatic process, implying that it's a kind of very early developmental process to express your suffering in physical terms, as the infant cries and shakes and holds the breath, turning red in the face and so on. This is like a childish way of expressing distress. So this is built into the whole thing, and it's kind of ironic. Years ago, David Goldberg, a British social psychiatrist, wrote a lovely little paper when she talked about talking to a Tibetan Lama and describing this idea of somatization, and the Lama said, that's a very interesting idea. That could be very useful. If you're having a lot of mental confusion and it's interfering with your meditation, you could just take all of that confusion and put it in a pain in your foot, and then you could get back to your meditation. So that completely turned the idea of somatization kind of upside down. Instead of saying this is a primitive defense mechanism or something, it implies that actually this could be a useful way to contain suffering in some ways. And I think it makes it an open question, at least conceptually, what the status should be. The whole area of bodily expressions of distress that are attributed to emotions is very important in general health care. Because, in part, as you'll see in a few moments, a lot of symptoms in medical care, a lot of people's complaints don't have a clear biological explanation in terms of a biological disease. And so psychosocial explanations are always available. You can always say, well, you're under a lot of stress, so that's why you have headaches. Okay. And therefore, we know who to refer you to or who should take care of you. So this dualism of thinking about different kinds of problems is mapped onto a kind of segmentation of the healthcare system, that there are people who are responsible for different kinds of problems. And if you come into the emergency room, they try to decide very quickly, do you go to the emergentologist or the specialist in internal medicine or physical medicine, or do you go to see the psychiatrist or psychologist? Again, there's a geographical, a spatial duality that reflects the conceptual duality that we're talking about. Nevertheless, we think that these things are related in certain ways, and the question is, how are they related? And one kind of theory of how things are related is this family of ideas of psychosomatic processes, that somehow the thoughts and the feelings we have are expressed or have an influence on bodily processes. And psychosomatic theory traditionally has been an attempt to build causal theories. That is to say, if you have a lot of stress and you're having trouble coping with it, you get physically ill. And maybe we could eventually trace all the links in the pathway, and we would have a neat causal explanation of how you go from feeling overwhelmed by certain events and feeling miserable to ending up with an ulcer or high blood pressure or some other problem. So that's psychosomatics. A competing not competing, a complementary idea really is the notion of sociosomatics, the idea that there are social events, social processes that are affecting your body and your experience, and things could be impact that way without focusing on the psychological mediation. And I'll explain that later and how that's quite common across many cultures. Most cultures, in fact, recognize sociosomatic processes. Not every culture recognizes psychosomatic processes, but virtually every culture we know recognizes a kind of sociosomatic process. That is to say, how you feel in your body and whether you get sick has a lot to do with the social world that you're living in. That's pretty widely recognized. As somatization as the concept developed, particularly in the 60s and onward, first with the work of Zbigniew Lepofsky and then a lot of other people working in consultation liaison psychiatry, people working in general hospitals trying to provide consultation to patients being seen in medicine. There was a shift that occurred in how the term somatization was being used, so that it had less to do with psychosomatic causation and more to do with illness behavior, that is to say, how people are acting. So the issue now was not what caused your pain, but really what is causing you to complain. Whether or not you have pain, what is causing you to feel such distress and come for help and so on. So that is, again, a complementary question. It's not precisely the same question, because it actually puts aside the question of whether you have pain or not in some measurable way, whether there are certain causes for it, and simply asks, what is making you distressed? Why are you coming for help? And why is that help either making you feel better or not? So that's a kind of a shift. And I'm going to, come back to this in some detail in a moment. So let me just come back over this notion of dualism, and you've probably encountered this idea before that Western medicine, Western psychology, in fact, the Western concept of the person is typically described as dualistic, that we have mind and body, and these are separate things in some way. This is often blamed on René Descartes, which is not entirely fair. It has an older history than Descartes, and I think Descartes occurred at a particular moment in history when he was concerned to carve out a space for science while not offending religious sensibilities, and so he articulated a way to do that and to go forward. But as I say, it has a much older provenance, this idea of this dualism. In fact, you can trace elements of it back to Greek medicine, where you had a dualism or often a trialism. You had three levels. You had sort of spirit, soul, and body. in sort of different models that existed thousands of years ago. So various ideas of dualism, in fact, are quite universal. You can go around the world and you can find elements of what we're calling mind-body dualism in most cultures. First of all, because there are some fundamental tendencies in human beings toward dualistic thinking. The anthropologist is it Needham? I guess it's Needham. Wrote about this kind of dualistic classification. And there's a famous book about left and right, and the fact that in virtually, again, many, many different religious and mythological systems deal with these polarities of left and right. And it's an interesting question to ask, is that polarity of left and right, to what extent is that a biological polarity? Because again, we have hemispheric laterality in the brain. To what extent is it a mythological construction based on just making polarities of other kinds, of good and bad, of light and dark, and so on? But those are ubiquitous. And then existentially, I think people everywhere come to see a difference between the finiteness of the body, in the sense that we get injured, we have a sort of a progression of deterioration over the lifespan in terms of our physical mobility, for example. But in our minds, we can be very mobile, and we can move about a great deal. So there's a kind of a duality there between the material and the imaginary in some ways, although not always conceptualized in precisely those terms, and that is going to be expressed in different kinds of dualisms. So even if those kind of existential things are you can find traces of them in very, very diverse traditions, the specific forms of dualism that we have in what I'm calling the West, for want of a better term right now, meaning Europe and North America primarily, in those traditions, Northern European traditions, has taken particular forms within biomedicine. And there are three ways in which it's important. I've already mentioned one, which is this ontological distinction between mind and body, and that carries over, that ontological distinction, into everyday life, because people think that there are real illnesses in which you can see something in the body, or in an x-ray, or you're bleeding, and there are imaginary illnesses in which you complain but nothing can be found. And there's a Yiddish expression, which my pronunciation is not good at all, but it's an angerette krank is Ärger von an Emisser, which means an illness you've talked yourself into is worse than a real one. This is the Woody Allen phenomenon, that suffering around an imaginary illness has potentially no resolution, because it's just feeding on itself, and it has no validation from other people, because again, you don't have the visible sign. So there is an ontology here, even among people who, in their broad conceptualization, abstractly at least, would say, well, it's all one thing, isn't it? I mean, it's all one world and it's all tied together. And I mentioned last time the study that Mark Moresco did with psychiatrists and psychologists here at McGill, showing that people made these kinds of dualistic distinctions between illnesses they saw as more biologically based and illnesses they saw as more psychologically based, even within the range of psychiatric disorders. So that ontology is still present. The second level, or second aspect of this dualism, is an epistemological dualism. And they're closely linked in the sense that there's knowledge that we get by hard observation and fact. And this, Foucault writes about this in The Birth of the Clinic, about the emergence of the clinico-anatomical pathological method. The idea that the way you can find out what a person really had is you do an autopsy. They come and they tell you they have headaches, but you don't know what to make of it. But later they die, and you can look inside and say, yes, look, they had this big thing in their head. That's what caused the headaches. I should say that's a very rare, exceptionally rare cause of headaches, just in case anybody gets alarmed. But anyway. So there was then the emergence of the idea that this kind of clear observation of something gives us real facts. The other thing, reports of suffering, are more doubtful, more uncertain, more ambiguous. They're epistemologically on shakier ground in some ways. So there's another kind of dualism between objective and subjective, if you will. Within medical semiotics, you have a distinction between symptoms and signs. Symptoms are things people report. Signs are things you can observe, and that ideally are hard for people to fake or to perform for you, so they cut through that. So for example, so we'll talk about today a little bit about conversion symptoms. If somebody his arm is paralyzed and you're trying to figure out, is it a neurological problem or is it a cognitive psychological problem, then one of the tests you may have is you take their hand and you drop it over their face. And if it misses their face, you think, aha, you see, they say they can't control it, but they're artfully making sure it doesn't hit them in the face. Of course, if they do hit themselves in the face and get bruised, you have a problem. You think that now maybe it is more real and definite, and it may or may not be, and vice versa for that matter. And I'll show a film today. I'm going to show you a different film than we had originally planned, but one that really illustrates this very dramatically. There's a final dimension to this dualism, and I think it's important recognizing that there are these different kinds of dualism, because even if we solve one, or even if we find a conceptual scheme that brings one together, it doesn't address all the other elements. And this third dimension, again, they're interwoven, the third dimension is a moral dualism between things that happen to you, accidents, illnesses that you're not responsible for, and things that you do to yourself. And again, you see this dualism all the time in medicine. People are trying to decide, should we feel sorry for this person and give them care because it's just an accident, they got cancer, what could they do? Versus, oh, they're alcoholic, they're really kind of doing it to themselves, aren't they? And so it's in that context that the efforts to medicalize problems and to biologize them is trying to struggle primarily with this moral dualism and this kind of distinction between things people are responsible for, things they're not responsible for. And that's also why, even after you solve some of the other problems, these things come back, and why so much is at stake for people. It's not just an abstract conceptual problem, how do we put together all these different levels? It's a big issue of how are you going to be treated in everyday life, and are you going to be held responsible for your problems? Okay, so it's in this context of these ontological, epistemological, and moral distinctions that the categories of somatization and somatoform disorders, which is the group of problems of somatization, that's the name for it, somatoform, which again, the shape of that word, the grammatical structure of that word tells you something. It's saying that these are problems that look like they're problems of the body. They're in the shape of a bodily problem, but the fact that they're in a psychiatric nosology implies, oh, but they're somehow a psychiatric problem. And because we're in a dualistic system, the fact that something is a psychiatric problem implies it's not totally of the body, that it must involve the mind, whatever that is, higher order processes in the brain, if you want. So this is another nice, we began with an image for William Blake of loss suspended over the abyss. And this is another Blakean image of Adam and Eve in the garden. And this represents, again, this moral dualism of struggles over desire and so on that get layered onto our notions of illness. So I became interested in this area not originally through cultural issues, but because I was working as a consultation liaison psychiatrist in a general hospital. So I was being asked to see people who had pain that couldn't be explained, or who were very worried about illness even though they'd been told there was nothing wrong, and a whole range of problems like this. Then I began reading the cultural literature and discovered that there was a significant literature talking about somatization and arguing that people elsewhere in the world, non-Westerners, that is to say everybody outside this little group that described itself as Westerners, that other people, meaning Asians, Africans, and so on, were more likely to somatize, to express distress in bodily terms. And I was struck by the notion that what could not be quite true, because in my everyday work in the general hospital here in Montreal, there were lots of people who had somatic complaints. And in fact, when you look at the early studies making this argument, comparing, saying that, say, Chinese are more likely to somatize, an early paper by Arthur Kleinman, very important figure in cultural psychiatry and working in Taiwan, where he wrote a paper called Depression, Somatization, and the New Transcultural Psychiatry or Cross-Cultural Psychiatry. The comparison that was being made was between people in primary care or in traditional healing settings in Taiwan and people coming to the Harvard medical system in Boston and to the Massachusetts Mental Health Care Center. So I mean, that was the implicit comparison, because he was just looking at a group of people, you know, in the ethnographic work that he was doing in China, but in the back of his mind, the back of everybody's mind, were the different clinics that they were working in that were in these highly specialized, differentiated healthcare systems. So it occurred to me that this is not a fair comparison. And I think we have to make a better comparison. So we, with a colleague, Jim Robbins, a medical sociologist, we decided to study somatization in primary care at hospitals in Montreal, and I'll show you some of the results from that. But the first problem we had was how to operationalize the definition of somatization. Because if you say what somatization is problems that are really emotional that are being expressed bodily, you have a very abstract idea, and the question is, well, how do you know? And there was, at that time, a whole literature on things like mask depression. The idea that somebody could be smiling, say they're not depressed at all they're complaining about is headaches, but they really have depression. And again, this struck us as a very confusing and you know, hard to substantiate claim. I mean, who decides that this is really depression? What is it you're looking for? If there's no independent measure of depression, then it's just a theoretical model imposing itself on something that could be interpreted different ways. So this was the challenge. And so we came up with these three very simple definitions based on what was already going on in the literature. It's really just a redescription of what was there, but that could be operationalized. And the first was people who have an identifiable psychiatric disorder like major depression or panic disorder. It's not hidden. You can ask all the questions and you'll make the diagnosis. But all that they're talking about to the doctor is that they have physical complaints. So if you take them aside and interview them, you can diagnose depression. But in terms of what they come to the doctor with, they're just saying, I'm fatigued, I have headaches. That's all they want to talk about. So that is a style of clinical presentation, if you will. The second area is people who, whether or not they have a lot of physical symptoms, are very, very anxious that they have a physical health problem. They're convinced there's something wrong with my brain, I think I have cancer, I think I have a heart attack. So they're really persistent, and this includes hypochondriasis and all kinds of other health worries. And the third notion that we found in these discussions of somatization was people who have what you could conservatively, parsimoniously, and purely descriptively call medically unexplained symptoms. That is, they have a symptom for which nobody can find a good explanation. And as I said, once you have that, it's very easy to come up with a stress or psychological explanation. Everybody has stress. It's not hard to sort of find something to pin it on, and that's another category, if you will. Please. Yeah, so you're raising the example of fibromyalgia, which, in fact, during the course of the time that we did this research, went from being something that people viewed as a non-entity to being of great interest. Initially, it was called fibrositis, which implied inflammation. I-T-I-S, itis implies inflammation. So then people did all these studies taking tissue samples looking for inflammation. They didn't find anything, so that was a big problem. And then so they changed the name to fibromyalgia, which implies connective tissue and muscle pain, which is, again, purely descriptive title. But then people decided, oh, we can operationalize the diagnosis of fibromyalgia. We'll look for people who have generalized pain in 4 quadrants of the body and who have tender points, where if you press them really hard, they jump. They feel a lot of pain. And if you have a bunch of these pressure points, you have fibromyalgia. And then people said, well, this is a disorder of pain perception, and it sort of got elevated from the zone of ambiguity and uncertainty and contestation into a formal diagnosis, which was important for people in rheumatology, because probably the single most common diagnosis in rheumatology is people with fibromyalgia. And it can coexist with other things, with rheumatoid arthritis, with osteoarthritis and so on, but it is extremely common. I'll come back to that because it's an interesting example and something that we did a little bit of work on, and it's an important example for the things that we're thinking about. But it does raise one point, which is what is considered medically unexplained is also an issue of cultural fashion in the state of medical science. So as we learn more and more things, certain things go from being medically unexplained to being explained. But at any given point, even with the amount of knowledge we have, it's also an issue of sort of our own charity. Do we want to say that, okay, it's pain due to tension in muscles? Fair enough, you're too tense, so you've got pain. That's sort of an explanation. The reality is we can't measure that very well. We think a lot of back pain is due to things like that, or due to very subtle, biomechanical things, but we mostly can't measure them at all. So it's just, do you want to credit people with that, or do you want to say, no, there's no good explanation at all? When you do that, when you say there's no good explanation at all, of course you create a real quandary. Because if there's no good explanation at all, and yet this person is saying, I'm in terrible pain, either you disbelieve them, or at the very least, they represent a great challenge to your own competence, because you can't give them a satisfactory explanation, you don't know what to do next and whatever. So that's the point to be made about this last category is it's ambiguously defined, or not so ambiguously, but it's a descriptive category of a certain kind of social or medical predicament, one for the clinician as well as for the patient. So the other term the term we originally proposed for talking about these kinds of problems was functional somatic syndromes. And that implies something a little bit different, because the term functional in medicine has tended to mean a disturbance of function. And in some ways within psychiatry, there was a distinction between functional and organic. Organic meaning there is something biologically wrong that you can see, so it's a gross biological, an anatomical or other kind of deficiency that you can measure. Whereas functional disturbances, the presumption was you can't see anything. Presumably it's some disturbance in the functioning of a system without there being a gross structural lesion. Of course, because that dichotomy was used in exactly the kind of situations we're talking about, it also took on a pejorative meaning. So to call something functional, if you're a neurologist, to call something functional is to kind of dismiss it, to say it's not really a neurological disease. We'll get the psychiatrist to see this person. Something funny is going on here that so we took those three definitions, which we were able to use more or less, operationalize in a way, and we went into a family medicine clinic and we interviewed 600 people, 700 people coming to see the doctor on a self-initiated visit before they saw the doctor. And we asked them, what are you coming to see the doctor about today? Tell me about your symptoms. What do you think your symptoms are due to? Could nerves or worries have anything to do with your symptoms? And so on. So what we found, first of all, was that these three definitions were largely non-overlapping. So even though when you went to the medical literature, the psychiatric literature describing somatizing patients, they tended to put all these things together. So the people at the middle of this Venn diagram were the ones that people were typically describing. They're depressed and they're complaining of a lot of physical symptoms and they're very anxious, there's something wrong, and all these bits were together. In reality, we found there are lots of people in each of these categories, but most of them only have one or other of these processes. So that's interesting in its own right, because it means, okay, maybe we need to think about different processes for these things. Maybe there's somewhat different things going on. Yeah. No, they existed in the literature, but people were not clear in making these distinctions. As I say, most people would talk about, there are three circles there, right? And you can see that they're overlapping in different ways. And so most of the literature was on that central group. But people would not frame it that way. They would just say, I'm talking about somatizing patients, and then they would tell their story about somatizing patients. So what we tried to do, this is a paper we wrote some years ago called 3 Forms of Somatization in Primary Care, where we tried to say, look, just for the sake of clarity, let's try to tease these apart. It's an empirical question whether this describes one thing or not. And we provided some evidence that the areas outside the overlap represented at least 50% of each of these categories. 40 to 50% of each of these categories. So that was a suggestion that maybe they're separate processes going on. And yes, there are worst case scenarios, since they're all common anyway. There certainly are people who have all three things going on, and they're the ones who are having the hardest time, and they're the ones that end up being the typical patient with somatization, as it were. So I'm going to tell you a little bit more about each of these, because, as I say, this is the way we sort of proceeded. And I'm talking to you about this now in the context of general medical care here in Canada. Perhaps it doesn't look very cultural to you yet, but I'm going to show you how, well, first of all, the argument I made last time was everything's cultural anyway, so it's fine to study whatever you want. But I'm going to try to show you how this way of sort of dissecting these concepts gives us a useful tool for starting to think about cultural variations in a way. So the first category is, I'm going to talk about people who have an identifiable psychiatric disorder, primarily depression or anxiety disorders, which are the most common disorders in primary care and in the general population, who present clinically only with physical symptoms. And why they present only with physical symptoms is complex, but the most basic reason simply is that if you are very depressed or you are very anxious, you have a lot of physical symptoms. It is in the nature of depression and anxiety that you have physical symptoms. I mean, you can argue it's in the nature of the human condition that you have physical symptoms, but they are more when you're anxious. When you're anxious, you have lots of adrenaline circulating, you feel shaky, you may feel palpitations, you have all kinds of things that come with the physiology of anxiety. When you are depressed, you have increased muscle tension, you have slowed gut motility, you have a lot of things, and 90 to 100% of people with severe depression have physical pain of some kind. So that just seems to be part of whatever these syndromes are, part of whatever the underlying biology of these syndromes are, they give rise to symptoms. So on the one hand, we'd say, so it's no mystery that somebody who is very depressed or very anxious has physical symptoms. What's interesting is that even though they also have potentially emotional, cognitive, other kinds of symptoms, some people only talk about the physical symptoms to the doctor. Or if they talk about the other symptoms, they attribute the emotional symptoms to the physical problem rather than vice versa, let's say. These are some of the symptoms that are commonly associated with depression. Some of these symptoms, like weight loss, as I already mentioned, constipation, and so on, are viewed as vegetative symptoms of depression. That is to say, again, they're core symptoms of a severe depression in which there's some physiological dysregulation. And in fact, they're even used as diagnostic criteria for major depression, that this is part of what tells you this is a serious endogenous or melancholic kind of depression. So what we did in our study was we asked people, what are you coming to the doctor for? We got all that information. We asked, they gave us the symptoms or whatever other reason they were coming. For most people, it was a symptom of some kind. And then we said, what do you think is causing your fatigue, or what do you think is causing your headaches? And then if they had not brought up anything psychosocial at all, we said, do you think nerves or worries could have anything to do with causing your headache or your fatigue? So then what we did was we did a separate part of the interview where we used the diagnostic interview schedule, which I mentioned last time, a structured diagnostic interview for making, in this case, DSM-3 diagnoses. And we looked for major depression, panic disorder, generalized anxiety disorder, a variety of other things. So when we do that, in our case, about 10% of the people coming to family doctors have major depression or an anxiety disorder. And that's a common figure. I mean, it varies in different samples and different settings, but it's often 5 to 15% or so. It's a fair number of people in primary care who have depression or something else. Of those people, however, 85% of them did not report a psychosocial symptom as the reason for coming to the doctor. So most of those people did not say, I'm coming because I'm depressed, I'm coming because I'm anxious. Most of them said fatigue, pain, or some kind of musculoskeletal pain. Those are the most common reasons for coming to the doctor. And that cut across different levels of education, different cultural backgrounds. So it was a very diverse group. This was done here in Montreal at two of the McGill teaching hospitals in the Côte-de-Neige area. When we asked people, and so 15% of the people here on this diagram, the pie chart, are listed as psychosocial presentations. So that was we classified anything that was vaguely psychological or social, like, oh, I'm coming because I'm under a lot of stress. Okay, fair enough, that's psychosocial. Or I'm depressed, or I'm having trouble at work, or anything like that. So, but only 15% of the people with depression and anxiety disorders presented that way. When we said, what do you think is causing your problem, 34% of people said, I think it might be because I'm under a lot of stress. So of those people who said, no, but I have headaches, a significant chunk then said, okay, but it's because of stress, because of something emotional. So those people we called initial somatizers. And they're showing what in the family medicine literature at the time was called ticket behavior. That is, if you want to go to the doctor, the appropriate thing to have to tell your employer, your teacher, or your family, or the doctor themselves is, I have a physical symptom. So you may well know there are other things going on, but this is the appropriate way to go. But there was no, even though it looks like somatization, there was no difficulty in getting people to immediately make the connection. Okay. But then that still left half those people. So of those remaining half, when we said to them, do you think nerves or worries could have anything to do with causing your problem? Half of those people, again, 25% of the initial sample, said, yes, I think it has something to do with my problem. So those are facultative somatizers. That is to say, if they're given the alternative explanation, they're willing to work with it. And then finally, we had a group of people who persisted in saying, no, it has nothing to do with it, even though the way we diagnose depression was not through some kind of mysterious process. In the diagnostic interview schedule, it asks, have you been feeling sad or depressed? And so these people said yes. Or have you been feeling suicidal, and have you been crying a lot? So they said enough of those questions that they had significant depression when you asked them point blank, but they did not see them as being connected to their presenting complaints. Now, it's possible that the reason was the complaint was totally unrelated, but we went back and looked very specifically at all these things, and the complaints were primarily fatigue and pain. So things that very plausibly could be related to their depression, but which they did not connect. So this is important, and this is important that this is the case for people across the board. This has been replicated in other places, in Spain and other places, so we know that, that this applies quite broadly in other settings. And it's also important in terms of the consequences, because these were the rates of recognition of depression by the family doctors. So depending on how you present, the doctor would either say, okay, this is a depression, or in the case of the people who persistently didn't make any connection, very few of them, less than around a fifth of them, ever over a year following the initial presentation, ever got diagnosed as having depression or anxiety. So there's something going on here in the negotiation between the patient and the doctor as to what is the problem that is very heavily influenced by people's style of presentation. Please. By both, yeah, I agree. I think it's by both. On the part of the patient, one of the things we looked at, in this study we didn't look too much at stigma. We looked at some other things. One of the core things we looked at was attributional style. That is, if you have a headache, what would you think it was due to? And that does predict this style of presentation. People who make psychosomatic explanations all the time are more likely to report a psychological link to their symptom. People who think that physical symptoms are a sign of physical illness only are more likely to persistently present this way. So that's one component. We know that we also ask people about help seeking. Would you go for help? And we ask them about physical illness and psychological illness. So again, people who would go for help for psychological illness are less likely to somatize in this sense. Those who would not are more likely. And we know from other studies, for example, a study by Raghuram and colleagues in India, where they argue and try to show indirectly at least that somatic illness is much less stigmatized than psychological distress. And so therefore this is following a pathway that is safer for people, and that is going to get them help, but not at the risk of having labeled themselves as having a personal problem or a stigmatized problem. So that's undoubtedly part of what's going on. And as you said, it's also an issue on the part of the clinician, because clinicians are reluctant to make psychiatric diagnoses, or were at this time. This is 20 years ago or more now. And one of the issues at that time was the antidepressants that we used in medication were difficult to get people to take because they had a lot of side effects. And so it was a real pressure on the doctor to kind of work with that. And so it was, in a way, just nice to collude with the patient and say, fine, this is not depression or whatever, you don't even think like that, and we'll just go along the path. We'll do some more investigations. We'll look into this. Yeah. We haven't done a similar study in recent years. There are some similar studies fairly recently, and they find not a huge difference, including the rate of recognition of depression is still not as high as you might expect it or want it to be. And that has again to do with other things about the doctor-patient interaction we can talk about further as we go along. I'll leave it at that for the moment. I think things have changed with the SSRI antidepressants that are much easier to prescribe. There's been an argument that they are overprescribed at this point, and that it's just very easy for a family doctor to sort of write a prescription for one pill a day that doesn't have that many side effects, and that these are being overutilized. That may be the case. One other point I wanted to make about this is we did a one-year follow-up, as I mentioned. That's part of how we looked at this issue of recognition, but we could also look at how are people doing a year later. And one of the findings out of this is that the persistent somatizers, the true somatizers I'm calling them here, actually did not do worse than the other people. So what this raises is the trade-off that exists, and this may also be related to stigmatization. If you acknowledge you have depression, you get treatment, but you also now have to live with that stigmatized condition and that view of yourself as having this problem. And since we know that, first of all, that a lot of depression is self-limited, mild to moderate depression will get better, even severe depressions get better on their own to some degree. And we know that the antidepressant medications are not as good as we thought they were. That's one of the big revelations, if not scandals, of recent years. It's quite possible that there's a complex trade-off going on for people between having a mild to moderate depression, not having it labeled as such, managing with it somehow, getting better, and not having then the consequences of having been labeled as somebody who has depression, versus saying, oh, I have depression, I'm prone to recurrent depression, all the other story that comes along with that may not always have a good outcome. And I don't think we can make a firm conclusion. I think that we don't know enough about this, and we do know that the simple story and the very positive story that we were told of let's just find everybody who has depression, let's treat them all aggressively, everything will be great, is not correct, it's not sufficient. And that there's definitely a set of trade-offs going on. The other point to be made about stigma here, and again I think we'll come back to it in a variety of ways, is the great hope with destigmatization campaigns in psychiatry. We're in the midst of a huge one here in Canada coming up through the Mental Health Commission of Canada, has been that if we explain mental illness as a biological phenomenon, people will accept it and it will be destigmatized. So instead of people viewing depression as a weak character or lack of energy, lack of gumption, you should pull yourself up by your own bootstraps, that we would say, no, it's an illness like anything else. It's like catching pneumonia, you need an antibiotic, you need your antidepressant, all these kinds of analogies, or a chronic illness like diabetes, and you need your ongoing medication to prevent. The hope was that those frameworks would really destigmatize. And the evidence is, at least on a global scale, that that's not the case. And in fact, it works the opposite in many places, because people understand the biological explanation as telling you something about the intrinsic character of that person, the intrinsic nature of that person, something genetic, something constitutional, and so it actually confers another kind of stigma. And particularly in many Asian cultures and other societies where people understand chronic mental illness, depression, other things like this as being, or anything that's explained biologically, let's put it more clearly, as being intrinsic to the person and therefore expressed in their inheritance, being passed on to other generations, this has very negative social effects, not only for the person, but for their siblings, for their family, because it's, oh my God, my sister will never get married now because I have this biological illness, so now it's a mark on the family. So it's this kind of hope that this would be a simple solution and that people would just say, great, it's an illness like any other illness, and now we should just be compassionate, has not played out as simply as people thought. Because of the cultural meanings of things like biological illness and so on. Yeah, so this is a complex set of issues again about how do you view an illness or an adaptive problem like depression or anxiety. Do you view it as just something that's happening to you, like it's the machine's not working right, I better take my pill? Or do you view it as part of a process that involves your own agency, your own will, your own strategies for coping, because then maybe there's something you can do about it? So there's a study, take the example of anxiety, there's a study years ago by, I think it's by Malcolm Lader, showing that people who were being treated for panic attacks and who were given alprazolam, an anti-anxiety medication, and cognitive behavior therapy did worse than people who are just getting the cognitive behavior therapy. And there are two possible explanations. One is that if you're medicated, you're not going to be fully alert and able to engage and so on. But the other is an attributional process. That is, what happens with many people when they get these medications, they may not take them all the time, but they have them there, so they have them wrapped in a little piece of tinfoil in their pocket, and they know that it's there whenever I need it. So psychologically, it's functioning as a kind of safety net, but it's preventing the person then from feeling like I've really mastered the situation. I kind of know what to do. I can handle this on my own, which would build up, you know, if you successfully acquired that attitude and showed yourself that you could do it, it would give you a much greater sense of self-confidence. So there's this dilemma again between, on the one hand, wanting to say, look, it's not your fault. This is part of the human condition. It happens to lots of us, et cetera, et cetera. Don't feel ashamed. On the other hand, don't think of this as something totally divorced from your mental attitude and your own capacities and so on, because you can master this. So how can we have it both ways, you know? Or is there inevitably going to be a trade-off that if we go down one route, you're going to have to struggle with the fact that you feel like, well, if only I was a little better at this, I wouldn't be sick, kind of, and you're going to feel the shame and the self-stigmatization, the self-stereotyping, the self-handicapping that goes on with that. So you're raising an interesting question. So because you're pointing out that benzodiazepines are not the recommended first line of treatment for panic disorder. I should say it remains that benzodiazepines are very widely administered by family doctors and by psychiatrists and by everybody for people with anxiety disorders. I see this every month in the emergency room, people coming in with these medications and people being encouraged to be given these medications. So that's the reality. But you're raising an interesting question. Many people would feel if you are going to give medication that an antidepressant is a better medication to give. And what that does for panic disorder is it can block the worst panic attacks for people, so then they feel like they've got a bit of a safety net and they've got a bit of a handle to then go ahead and use other strategies. And the question would be, how does that play out for people? And I should say that even with benzodiazepines, it's not necessarily going to work that way for people. There are people who can take it or have it available and still invest very well in using other strategies. So the point simply to be made is that what's at play even with these pharmacological treatments is what is the meaning of this treatment to people. There's no way to escape from that. And that part of the efficacy is the meaning and part of the side effects is the meaning, if you will. And so we have to understand that. And those meanings are culturally embedded. We live in a culture now in which taking pills has become much, much more acceptable than it was 20 or 30 years ago. When I was studying psychology in the early 70s or late 60s, early 70s, there was a rise in the use of methylphenidate for attention deficit disorder. And then there was a big article in Science decrying this and saying this is a mistake, we're over-medicating, et cetera, and then it appeared to go down. And here we are several decades later when this has happened in an even larger scale with much less, I say plenty of criticism, but much less actually restraint and much less pushback against this. And I think it's because larger societal attitudes have changed so that it's just much more acceptable for people, the idea that they might take different medications or the kids might take medications and so on. In asking where is the stigma when so many people are taking psychiatric medications, does it mean stigma has decreased or that it's changed its nature and it's attached to different things? That's possible. That there's less stigma attached to taking medication. There may be stigma attached to certain kinds of inappropriate behavior, or there's more stigma and anxiety attached to doing poorly in school. Or to saying, in the case of ADHD, for example, there's more stigma attached to saying there seems to be a family problem here and let's talk about the family than there is to saying, oh, this is a brain disorder and we'll give you some medication to help you tune your attentional system. Less stigma and also less threat on many levels for people to treat it as in this kind of neuropsychiatric way than to say, look, let's look at why this kid's having trouble sitting still in the classroom, concentrating, and so on and so forth. Or even the larger question, which Jack Panksepp has raised, a affective neuroscientist who studies the development of emotion systems. And one of the things he studied is play in rats. Rats play, little baby rats like running around and nipping each other and everything else. And based on that, he draws a lot of analogies from rats to human beings, some of which are compelling, some of which are not. I should say also he discovered that rats also laugh. That if you tickle rats, they have very high frequency laughter. It's outside the human range, but I think it's fantastic. You can tickle their bellies and you can hear these, they can show on sonograms these ultrasonic little giggles that the rats are making. So it does make them much more human and adorable in some ways. And in any event, looking at this sort of rough and tumble play among young rats, he pointed out that human beings too, young human beings do a lot of rough and tumble play. There's also a gender difference. Boys do more of that than girls, but both boys and girls normally do some of that. And what we do in our society, of course, is we take boys and kids at the peak of that time, and we say, now please sit in a classroom and don't move for 6 hours a day while we talk to you. So the fact that a lot of kids have trouble in that setting might not be pathology at all, or the pathology is the social pathology that we've created a weird situation that doesn't reflect human biology and development in that point. So that kind of argument, which is possible, is very hard to study and very hard to make in many ways, because it's so much about just this is the way we do things, this is our culture, this is common sense, how could we overturn this kind of, Yeah, this is a recent study. I think it's from Canada, this recent study, and it's a great bit of evidence in favor of this argument that the correlation, the likelihood of being diagnosed with attention deficit disorder is directly related to how young you are in the classroom. So if you happen to be, because of your birth date, you happen to be in the younger group in your class, you're much more likely to get that diagnosis. So you could simply say, well, these are just kids who are developmentally a little bit less mature than the other kids. There's nothing wrong with them. It's just harder for them to sit still because they're still, but the response of the system, because we have a very limited set of responses available, is to label them with a disorder and give them medication. And one of the other dilemmas, since we're talking about stigma and medication, so one of the other dilemmas is, once you're given medication, it is a social mark. I mean, the meaning of stigma, of course, is a mark, right? So now you have the social mark that follows you everywhere. And every doctor who opens up the chart and says, oh, you got such and such medication, when did you last take that, It now is, becomes a self-perpetuating reality in some ways. And it's hard to break away from that completely, or to have a new identity now. So these things become part of people's personal histories and identities, internally, but also in communication with others. Okay, let me shift to the other kind of, second kind of somatization I wanted to talk about, which is these medically unexplained symptoms, or functional somatic symptoms, if you will. These are extremely common. Studies in family medicine suggest that probably 15% or more of patients who come in primary care, 15 to 20%, have physical symptoms for which there's no clear medical explanation. As I say, that's partly just because of the limits of medical technology. I mean, people have aches and pains. We think that, if you sit hunched over the computer, you're going to have back pain, but there may be nothing to show in your back. These are very subtle phenomena. We don't have the technology to show it clearly, but it's reasonable that there's something there. But there are lots of other complaints people have that are hard to make sense of. These are the most common. This is from a community survey now that we did, again, in the Côte-de-Neige area. We looked at 2,400 people, and we asked them, in the last year, have you had a physical symptom for which a doctor could not find an explanation? So these are ones that troubled people enough that they went to the doctor, but the doctor could not find an explanation. So, interestingly, almost 10% of people have had such a symptom in the last year. And these are the most common symptoms. 1/3 of them are some form of musculoskeletal pain, abdominal pain, ear, nose, and throat symptoms, fatigue, and dizziness. There are other ones if you go down the list. I think I might have another slide here comparing what men and women reported. You notice that somewhat more women than men reported symptoms, which is commonly the case. Across many different cultures, women tend to report more somatic symptoms than men. The extent to which they do varies culturally, but the preponderance of women is consistent. And they're basically the same. The only difference is men reporting some urogenital symptoms. I'm not sure what that's about. Ear, nose, and throat. So I don't know beyond, I'm trying to remember now how those were grouped. These are our groupings of things based on people's free reporting of symptoms. So it may be sore throat or runny nose or earache or a whole lot of other things. When you ask, so what is associated with having these kinds of symptoms, what you find is that the only thing that's significantly associated here, because all the confidence intervals span one, so the only one that actually is significantly associated is the General Health Questionnaire, which is a list of symptoms of emotional distress. Feeling you couldn't cope with things, feeling worried and anxious and so on. So there is an association. It's not a huge association. It's actually a relatively small association, but there is a connection between emotional distress and physical distress. This is an important point because, again, if you go back to the older psychodynamic literature, there was an implication in the theories of somatization that if you can express distress in emotional terms, you don't have physical symptoms. If you can't express it in emotional terms, it's blocked, and somehow that energy or that tension or that conflict will be expressed in physical symptoms. But most of the research shows that, in fact, emotional stress and physical stress are positively correlated with each other. That means the more emotional stress you have, the more physical distress you're likely to have. So there's not an either or, they actually go hand in hand. And this is another little bit of evidence that that's the case. I should say, I don't know if it's on here, let me just see it's on here. Yes, one of the things, the point of this particular study, I may say a bit more about it at a later point in this lecture series, was really to look at help seeking among immigrants in the same urban neighborhood. So those 2,400 people that we were surveying in the neighborhood included samples from the community of people who had come from Vietnam, from the Philippines, and from the Caribbean, all living in the same neighborhood, because what we were interested in is here are people who are in the same healthcare system. Theoretically, they have the same level of access to the healthcare system. It's free access to care. And how are they using it? And we found that they used medical care the same way, but they did not use mental health care the same way. And I'll say more about that later in the course. So here you can see immigrant status. Again, it was not really associated with reporting more somatic symptoms. When we break it down more, I don't know if I have a slide here showing it, we did find some evidence when we broke it down by groups and so on, that if you talk about not unexplained symptoms, but just somatic symptoms in general, that the Vietnamese sample reported more somatic symptoms than other groups. But the Vietnamese sample was also a sample that included a large number of people who had come as refugees. So it is potentially a more distressed group, at least initially, and I'll say more about that later. Actually, I will talk a bit about Vietnamese idioms of distress. In terms of medically unexplained symptoms, every medical specialty has its own families of medically unexplained symptoms. So these are lists in some of the different, really broken down by organ system or medical specialty. If you're an ear, nose, and throat doctor, you see people with burning tongue syndrome or tinnitus, ringing in the ears. If you're in cardiology, you see people with chest pain, but a normal cardiogram, nothing wrong with the heart as far as you can see. In gastroenterology, very common complaints are irritable bowel, where people have constipation or diarrhea. Nothing can be found to explain it, or abdominal pain, actually, the most common symptom in irritable bowel. And so each area has these things, and these are among the most common diagnoses. That is a big chunk of patients in each of these specialties. And most medical specialists are a little bit irritated by these patients. They're not the exciting ones. They're not the ones for which there's a clear-cut diagnosis, a clear-cut treatment, etc. But they're the people you have to contend with. There are exceptions. They're rheumatologists, whatever, who are very happy working with fibromyalgia. There are different groups who make it their calling kind of to work with these kinds of patients. But in general, there's a kind of stigma attached to this because it's not well understood, clear-cut problem, clear-cut diagnosis, and always an implication that maybe people are complaining for no reason or complaining beyond what's reasonable in some way. Now, I should say that the fact that they're on this list and that they're medically unexplained does not mean that there may not turn out to be clear biological explanations for these things. It's just a question of where we're at right now with knowledge and with the possibility that there are other processes going on. Now, these kinds of medically unexplained symptoms are also influenced by culture. So the way that people diagnose in these epidemiological studies somatization is usually not with unexplained symptoms, because that's hard to figure out. You ask people for symptoms in general. In the case of the diagnostic interview schedule, you have a list of a bunch of symptoms you ask people about. And you do say, did you ever see a doctor for this? And did the doctor have an explanation? And you write in the explanation, and then later on, because these are done by lay interviewers, later on a clinician is supposed to look at these and decide, is that a plausible explanation or not? And if it's not a plausible explanation, it counts as a medically unexplained symptom, and you add up enough of these, and if you have a lot of these, then you get a diagnosis of having a somatoform disorder. When this kind of work was done in the United States, and they looked for people who had lots of medically unexplained symptoms, they found lots of people who had a few, but very few people who had many. And I'll say more about that in a moment. But when they did this in Puerto Rico, they found lots of people who had medically unexplained symptoms. And in particular, they found lots of people who reported some of these symptoms of fainting, of paralysis, of temporary loss of neurological functions, loss of consciousness, and so on, and this was very strange. And it led to a very high prevalence of somatization disorder, the most severe form of somatoform disorder in Puerto Rico from the Puerto Rican ECA study. And this was a big question, what's going on here? And this is some analysis from later studies showing that part of what's going on is if you look at Puerto Rican culture-bound syndrome or idiom of distress or some mixture of the two called ataques de nervios, nervous attacks, that prototypically what that consists of is a person gets some bad news or something happens, they become extremely agitated and upset, shouting loudly, crying out, and they fall unconscious to the ground or show other extreme behavior of that type. So this is a common reaction to very bad news. You can find some YouTube videos online showing people having these reactions. There's one where people are at an airport and they've just heard that there's been an airplane crash and people are showing these dramatic responses. I say people from every culture would show a dramatic response, but there's a particular cultural script for what this looks like, and it's called an ataques de nervios, and it's understandable to other people. It doesn't mean you have a psychiatric problem per se. And as a result of this, when you go and do this checklist with people and saying, by the way, have you ever had a period where you lost consciousness? Lots of people say yes. Whereas in the United States, very few people will say yes. So you have an interaction then between the basic tools we have of trying to ask about symptoms and a cultural framing of a behavioral pattern here that may be part of a syndrome and part of a way of talking about distress. So, and ataques de nervios is one of the best studied of these syndromes because there's been epidemiological work and a lot of other things, so we know something about how it works. I'll come back to that. In DSM-3 and 4, there's a group, as I mentioned already, of these somatoform disorders. This is the list in DSM-4 of somatoform disorders. And these are important partly because, again, of the segmentation of care. Because if you go to a hospital and you have abdominal pain, you get to see the gastroenterologist. But after the gastroenterologist decides, I can't figure out what's going on with you, there's nothing wrong here, he calls a psychiatrist or a psychologist and says, help. And so these disorders serve the function of plugging the gap in the system. And it ensures that everybody, no matter what their problem, gets a diagnosis. You have pain, we can't find the source of it. Okay, you have pain disorder. It's a psychiatric problem. You see how it functions, a little bit of magic there where we just fill the gap. So it's a very important institutional function that is problematic in certain ways partly because we don't really understand well these problems, and partly because it carries the stigma again that we're going to ask the psychiatrist to see you. When the psychiatrist arrives and says, your doctor asked me to see you because you're having a lot of pain, the person's first reaction is, why did they send a psychiatrist? I'm in pain, I don't need you, I need a painkiller. So you have a real dilemma of negotiation about what it is you're going to do to help people, understandable. I'll just describe these disorders very briefly for you. Somatization disorder, which in an earlier iteration was called Briquet syndrome, and before that was called hysteria, essentially, is a syndrome of many, many unexplained symptoms. In DSM-4, I think 3 or 4, you had to have 13 symptoms unexplained. So lots of different symptoms. In DSM-4, it's simplified in a way, the diagnosis. And they have to be symptoms in all different physical systems. So it's not just in one area. It's not just, let's say, fibromyalgia. All the symptoms are in the area of musculoskeletal pain for the most part. And it's viewed as a lifelong problem of experiencing many somatic symptoms and being disabled by them. The risk associated with it is that you'll get all kinds of medical investigations and procedures and end up with further problems created by that, and so it's a significant issue for people. I should say that in the ECA studies, the United States, the epidemiological catchment area studies, when looking for somatization disorder, they found almost no cases. So this had been a well-described syndrome in Washington University in St. Louis by Samuel Gouset and the group there. And Chris Bass, a British psychiatrist, then published, I don't think I have the slide here, but he published in a book on somatoform disorders, he published a chapter on somatization, and he had a little diagram of Missouri and the surrounding states, and he said, somatization disorder is a culture-bound syndrome of the American Midwest. And some clue as to what might be going on there happened some years ago when psychiatrist moved from the Midwest to Vermont and was operating in a different environment, and discovered that people who in the Midwest would be labeled as somatization disorder in the East Coast get labeled as borderline personality disorder. Because if you talk to people with borderline personality disorder who have a lot of emotional distress and a lot of things going on, they have lots of physical symptoms, all kinds of physical symptoms. And they often have all kinds of medical procedures to deal with those physical symptoms. So this sort of domain distress in every domain gets looked at. It's like the famous Parses and the elephant kind of story, you know, that to a psychiatrist in one part of the world, what's interesting is the list of somatic symptoms, and another part of the world is the list of relationship or emotional symptoms. But these are people who are distressed across the board. So that may be part of what's going on and why these things were not always detected. And that's both on the part of the psychiatrist, but also on the part of the person who's suffering. Conversion, sorry, please. Sure. Well, hysteria is the sort of older term. In fact, it's a very old term. It goes back to Greek times, and the origins of the word have to do with the notion of a wandering womb. That's why we get hysteria. So the definition is the idea that the womb would wander around the body and cause all kinds of symptoms by pressing in different areas. And so it has a very gender-specific or sex-specific definition in terms of how one would get those symptoms. And there's some continuity in descriptions of symptoms going back again a long time ago up to the present. And of course, hysteria was right at the center of the emergence of psychiatry as a discipline in the work of Charcot and then Freud and Breuer and so on, who moved essentially Freud from being a neurologist to being early psychiatrist. So, and the bread and butter kind of work that people were doing at that time was dealing with people with conversion symptoms and hysteria. What happened with DSM-3, there's a historical paper that came out around the time of DSM-3 called Hysteria Split Asunder, in which the whole variety of things that were put in hysteria got put into 3 different places in DSM-3. Into somatization disorder, into histrionic personality disorder, and into conversion disorder. So somatization disorder I've already described. These are people who have many, many different kinds of distressing symptoms that are medically unexplained. Conversion disorder is a situation of people who have single or a few symptoms that are pseudo-neurological. That is, they look like a neurological disorder, like paralysis, blindness, seizures, for which there's no biological explanation. So somebody looks like they're having seizures, but if you measure their EEG at the same time, it's normal. So these are behavioral seizures, if you will. And that's literally how the diagnosis is made these days. You have a split screen monitor, and on one side you're recording the EEG, and the other side you have the video of the person, and you can see there they are thrashing around, looks like a grand mal seizure, but there's no abnormal electrical activity in the brain. So you can sort of fairly definitively say whatever this is, it's not a seizure. And similarly for other kinds of problems that you try to show that the expected neurological thing is not there at all, and so what you have is something that looks neurological or looks like the person's map of neurological. So if somebody gets, let's say, numbness, they will in the hand, they will not get numbness following the actual pattern of the dermatomes that reflect the nerves. They would get what's called glove anesthesia. The whole hand gets numb, which is a lay notion of how it should be, but not an anatomically correct notion. So it's those kinds of mismatches that are the clue to the neurologist that, wait a minute, this doesn't make sense. It does not follow the actual structure of the nervous system. It's really being driven by the person's model, their mental model of what this illness should look like. So those are conversion symptoms. And the third area, as I mentioned, is histrionic personality. So histrionic personality now is viewed as a personality style in which a person is very dramatic, very emotional, very vague and circumstantial about things and so on. So the prototypical description of hysteria, again, was all these 3 things together, and these are like the early cases you can find in Freud's case studies. And this, with DSM-3, was an attempt to say, okay, there might be something in each of these areas, but they don't all go together, and there was evidence that they don't all go together. So let's separate them out, and we can study each of them separately and look at them. So that was the argument. And in terms of taking hysteria and turning it into somatization disorder, I mentioned the intermediary was Briquet syndrome. This is what, again, the St. Louis group proposed, coming out of the work of a French neurologist, Briquet, who described people with many different symptoms and in a way that they felt, fit the kind of construction that they were working with. The other things listed here are hypochondriacal disorder. So these are people who are very worried about being sick, may or may not have a lot of symptoms. Pain disorder, so this is people who are complaining of pain beyond what would be expected or can be explained by their physical condition. This is, again, another problematic category because, as Ron Melzack here at McGill and other people argued, we don't really know what the right amount of pain is for any given thing. There's huge variation. For the same injury, you can break a bone, exactly the same bone, or have a dental procedure, exactly the same thing, and there'll be enormous variation in terms of what people experience, so who's to judge? Not only that, but if you think you can judge how much pain somebody is in by how they're acting, it's not the case. In fact, our ability to judge how much pain somebody else is in is very poor. And clinicians' ability is very poor. Clinicians think they can tell how much pain somebody's in, but there have been studies literally where they put an actor there and say, I'd like you to pretend that you're in a lot of pain, or somebody who's in pain tell them, I'd like you to pretend you're not in pain, and you can show that actually clinicians are no good at judging at all. So it raises a lot of issues because a lot of decisions are made in clinical settings based on nurses or doctors' subjective impression of what does a person really need, and are they over or under reporting, when in fact it's not so straightforward. Body dysmorphic disorder, which is quite a different thing from some of the things we're talking about, which are people who are convinced that there's something misshapen or ugly or wrong with their body. And this comes up again in hospital settings a lot because people come for plastic surgery. People say, I must have my nose changed, it's too big. And so there has to be some decision. Is this a reasonable request? You can see what a sociological conundrum this is in terms of what's a good nose to have. There's a whole history on that. You can read Sandor Gelman on a whole history of that. Or people who, I remember one of my colleagues had a patient who insisted that her eyes were too close together, which nobody else could see. I mean, that's the other issue, that some of these things you would agree and say, yes, you need, plastic surgery maybe will help you because you have some deformity. I mean, that's what the medical side of plastic surgery is supposed to be addressing. But then there are these other things that appear imaginary or delusional or so on. So this is a category for that kind of concern. The latest theories are that this is most closely related to obsessive compulsive disorder, actually, in which people are sort of focused in on some aspect of their body and kind of obsessing about it in a way that's problematic. And then we have these two residual categories, which is typical for the DSM, that there are always these sort of wastebasket categories. If you have some of these things but you don't reach full criteria, you go in these categories. One of the consequences is these are always the biggest categories. Because if you just have a few physical and unexplained symptoms, there's no place to put you except in these residual categories. So they're actually pretty big categories, but they're not used that much.